I'll just introduce myself. I'm Julia Coffey, and I'm the Public Involvement Coordinator, and along with my colleague Sarah Den, we're responsible for doing all the public involvement work within research activities in the Trust. And tonight I'd like to present our three speakers, who is Richard Ashcroft, in the middle, who is Professor of Bioethics at Queen Mary, London, University of London, Sian Harding, who is Professor of Pharmacology at Imperial College, and Alex Lyon, who is a consultant cardiologist specialising in heart failure at the Royal Brompton and also senior lecturer at Imperial College London. So what we're going to do is we'll have the short presentations and then open it up for floor discussion. So it should be about 20 minutes of presentation from the speakers, and then the rest of the event will be up to you to contribute. So I'd just like to welcome Richard.
Yes, thank you. Stimulating the cardiovascular system. Well, good evening. It's lovely to see so many people here. I'm going to speak quite briefly just by way of introducing some of the ethical issues before handing over to my medical and scientific colleagues, though I know they also have a deep and abiding interest in ethics. In fact, the first time I met Sian and I were both sitting on an ethics committee discussing animals, that's right, when I worked at Imperial, so we've all got a connection with Imperial. My interest in gene therapy and cell therapy started about 15 years ago, where I have been working on the ethics of biomedical research for about that length of time, and I'm interested in clinical trials mainly. And in my career at that point, I applied to join a thing called the Gene Therapy Advisory Committee. And the Gene Therapy Advisory Committee is a group of people appointed by the Department of Health to do two things. At that time, there was a big interest in the ethics and social aspects of gene therapy. There was a worry that gene therapy might be a kind of human genetic engineering, designer babies, and so forth. And there was an important report done to the Department of Health in the late 80s under a man called Sir Cecil Clothier, which looked into these issues, and one of the recommendations was there should be a committee set up to advise the government and Parliament as well about the ethical, social, legal and policy issues around gene therapy. But the other thing that the GTAC was meant to do was to look at specific proposals to do gene therapy trials in a whole range of areas, from cystic fibrosis, which you'll hear about in January, through haemophilia, through to other kinds of complex conditions. And it was in that capacity that I sat on that committee as essentially a member of a research ethics committee, and my old friend and colleague Adrian Lepper, who's here tonight, was also a lay member of that committee at the same time as me, and continues to be, although I hear it's about to stop. And one reason it's about to stop is that a lot of the issues that the committee was designed to worry about, or think about, reflect on, have been absorbed into the medical mainstream. So that's one of the things that I want to examine, really, is how far this kind of treatment will be common or garden medicine in the next 10 to 20 years, and how far it's something that should be treated as special and different and worrying, and how far it's just, well, you know, we have this science, we have this technology, it's reasonably safe. There are signs that some of it may turn out to be effective, although it's a long, hard road, and it's been a long, hard road already. And how far should we just take it in our stride? Now, the story of gene therapy has been, as I say, a long and difficult one. A lot of failures, a small number of successes, and some of those successes have come at the cost of certain very serious side effects in a handful of cases. So there was a lot of hope for gene therapy alongside some of the worries of it, and a lot of our expectations of gene therapy have become kind of moderated and damped down. And I think the same is going to happen with stem cell therapy. I think the same will happen. We'll try a lot of things, some of them will work, some of those things that work will turn out to have hidden pitfalls, and a few things will turn out to be really a benefit and really useful, but we'll make a lot of mistakes on the way. And some of the people that will bear the brunt of those mistakes are people who are most seriously ill, because when you're trying out a new technology and trying to evaluate it, trying to see if it works or not, it's often the most seriously ill that are keenest to participate, have most need to participate, the greatest hope that participating will give them some benefit, and possibly the most to lose as well. So that's an issue that I think is worth exploring tonight, is how we approach introducing a new technology to patients at a time when we don't know very much about it, we don't know what will be safe and what won't be. We'll have a fair idea from animal studies, but only a beginnings of an idea of how it will work in man, so to speak. The second sort of question is how you translate that into the mainstream. How does that become routine practice? When we decide that a technology will work, be it a gene therapy in heart failure or stem cell therapies, and by the way, we may well touch on embryonic stem cell therapies, but much cell therapy and much stem cell therapy is going to be adult-derived stem cells, so that's an issue to try and keep in mind. Much of this will be marginal benefit at high cost and possibly difficult to get into patients. So we're going to have to ask some difficult questions about cost effectiveness and about the relationship between need and value for money. And those kind of things are going to be quite difficult. And they're going to interact into quite complicated ways with the way the NHS is changing and the way people's attitude to paying for healthcare is changing as well. Another thing that's interesting, and it's happening even now, is that people hear about advances in cell therapy and advances in gene therapy, and they read about them on the internet, and they can hear about them happening all over the world. This is not an area where the Western world has a monopoly on progress, far from it. There are researchers in Iran, there are researchers in China, there are researchers in Latin America, and all sorts. And people will sometimes think, right, I have dread disease X, I can't get treatment for it, or the treatment I can get for it doesn't work anymore, I'm going to go to China. I'm going to go to, well, pick your country of interest. What you don't know, reading reports on the internet, is it safe? And what you don't know is it true? Is there anything to it? And it's an unregulated marketplace, and it's quite worrying sometimes what people hear and what they believe, because, after all, we believe what we need to believe to get by a lot of the time. So thinking about this as a global process is quite important as well. So, in sum, I think the ethical terrain here is complicated and it's messy, and there's a lot of what we're worrying about is going to be about fairness, and a lot of what we're going to worry about is about hope, and reasonable hope, and unreasonable hope. And I think those are interesting ethical themes that sometimes don't get as much attention as some of the more prosaic ones about informed consent and safety and so on. So just to throw those few thoughts out as a beginning, I turn now to Alex, who's going to talk more about the medical side.
Okay, thank you very much, and I'll just add my welcome to you all as I work at the Royal Brompton Hospital, so it's delighted to see lots of you here today. Just as a background, I'm a consultant cardiologist who specialises in heart failure, and I'll describe what heart failure is in a moment. I also am an academic researcher at Imperial College, funded by the British Heart Foundation, working in the research laboratories, and now with our new biomedical research unit, I lead up the heart failure component of studying potentially new treatments that might be appropriate to start introduce into the clinics, but all under the governance of research trials, and maybe in the discussion we can get onto what the elements of regulation of the trials are. So what I thought I'd do is just discuss a bit about the background as to the science of why we're looking at gene therapy, what is gene therapy, and where we've got to in terms of our experience now of some trials that were performed initially in America using a type of gene therapy, and what we're planning to do here in the UK as part of an international trial. So starting with the problem is heart failure, and that means a lot of different things to a lot of different people. And if you speak to the cardiologists, there are conferences held to define what heart failure is. So it's very difficult to be very specific. But in general, it's a problem of the heart muscle, where the heart muscle is weak. And the reason it's weak is because there has been some form of injury. And when there's an injury to the heart, it initially goes through a phase of compensating, where the rest of the heart can cope with the injury. But after time, it develops a vicious cycle of problems that trying to support the heart, but actually make it weaker and weaker. And a good analogy is your muscles in your arms and your legs. And if you go for a run, you can go for a certain distance before you get tired, and that's because your heart muscle is starting to fatigue. Your arm muscle is starting to fatigue, and in a way heart failure is a fatiguing of your heart muscle, which of course isn't allowed to stop and rest. It's got to keep beating. Now, when we explore the reasons of why the heart muscle fatigues, what has come out of many, many years of research is the fact that it doesn't matter what the injury was. Is it a heart attack? Is it many years of high blood pressure? Is it a problem with the genes inside the heart themselves? The result of this fatigue comes through a very similar process of the disease and changes in the muscle. So there's a common signature in the fatiguing heart. And within that signature, we can see what are the critical regulation points that are driving the fatigue. And it transpires within this that there are some very, very important points of regulation. And these points are called proteins. And our body is full of proteins which are regulating how our body works. And every protein in our body is actually coded for by a gene. So our body is full of different cells which are like the little units that make us up, and every cell is full of a group of genes which are like an instruction list of how the cell should work. And if it's a heart cell, how the heart should work. If it's a liver cell, how the liver should work. And so every protein has its gene. And what we know is there's a critical regulatory protein that goes down in the fatiguing muscle. And that makes the fatigue get worse and worse and worse, and the muscle get weaker and weaker. And the reason for this is because the gene is switched off. So it's a normal gene in all our hearts, and it's contributing to the normal function. And in the weakening or fatiguing heart, this gene is switched off. And the result of that is the protein levels go down, and therefore the heart fatigues. Now, if it's a protein that goes down, you would think that we should be delivering a protein therapy, because that would be the natural solution. If the protein is down, we want to deliver the protein back. The problem is that there's no way that we have no tricks or delivery of proteins into ourselves in hospitals. You can have an infusion through a drip of protein, but it only lasts a few hours. And yet this is a problem that's always there. So you can't have a treatment that's just with someone linked up to a drip going back home forever with this infusion going through. So the way to get round that is to deliver the gene back. Because if you deliver the healthy gene back, it will make the protein where you need it, and it can potentially restore the function of the heart. And that's the principle behind our gene therapy. So it's not that the gene is wrong or abnormal. It doesn't have a mutation in the the weakening heart. It's just it's been turned off, and therefore the protein has gone down, and by replacing it, we can potentially restore the function and strength of the heart. So how do we do this? Well, there are a number of sort of potential ways, but nature has found the solution for us, which is viruses. Now, when I say the word viruses, everyone gasps, because everyone sort of has visions of horrible green little things that sort of cause colds, particularly at this time of the year. But what viruses actually do is they are designed to deliver their DNA, their gene, the virus genes, into our cells, which is how they then make lots of little baby viruses, and then they get passed between us, and that's how infections occur. So they can cause damage, and then they make baby viruses, and they pass and spread. So in the laboratory, what we can do is take a virus, take away all the viral genes that make baby viruses, and replace them with our treatment gene. So suddenly you have a package which is going to deliver the DNA, the gene, because it's got the outside coating of the virus, but it's not going to cause the virus disease because you've removed all the virus genes to, in essence, make it safe to inactivate it. Now, back in the 1980s and 90s, when we first looked at how to use gene therapy in patients with different diseases, the types of viruses that were used were viruses which do cause diseases, colds, meningitis, other problems, that they had taken, inactivated and taken out the virus disease genes and put in the healthy gene. But there was always a little bit of concern because those viruses actually were disease-causing viruses. As a doctor, we had lectures in medical school about these viruses, so made you feel a little bit uneasy. What's actually happened in the last 10 years is we've discovered a group of natural viruses that don't cause diseases. So that's very reassuring. From a cardiology community perspective, we're fortunate in that these naturally caught viruses like homing to the heart. So they're very good at delivering genes into the heart muscle. So we now have a potentially more benign virus. I've got to be always open-minded about the fact that once we start using these in treatment and in people, we don't know, but at least starting with a virus that's not known to cause a disease is a good place to start. And then they're very good and effective at delivering the gene into the heart muscle. So we've used these to deliver a particular gene which we know is critical in this fatiguing process in the heart, and we started in the laboratory and assessed this and how it affected animals which had heart failure to see how they fared when they received the treatment, and the results were very positive and very encouraging. And then after a number of cycles of toxicology, screening and safety, there was the very first trials performed in America where they took this virus gene therapy and gave it to some people. Now, the way they did this was sensible because you may be aware of a pretty tragic circumstance that occurred in Northwick Park Hospital, where a group of actually healthy volunteers were given a test drug, and they were all given it at the same time. And nothing was expected, it had all been very safe, but sadly there was severe reactions of the immune system, and because you suddenly treated 6 people at the same time, you couldn't take it out. So in this trial, they started by taking one person, giving them a low dose, following them for 3 months, then enrolling the second person, following them for 3 months, then enrolling the third person, and following, and so forth, and slowly increasing the doses between the different people and getting a safety profile in the very first group of people. Once they had proven that it was safe, at least in the short time period of about a year to 18 months that they had followed up, they then started a larger research study, albeit still in small numbers, of people where they gave people either this gene therapy to their heart or a dummy drug, the placebo. And the critical thing in all our research trials is the person receiving the treatment doesn't know whether they're on the real medicine or the dummy drug, and neither do the doctors. So we have to treat everybody equally. We can't bias the influences of the results because no one knows. And they followed patients receiving either the placebo medicine or a low, medium or high dose of this gene therapy, and it's all relative because we don't really know what's low and what's high. We were guided by experiences both from how effective the low doses were to get into the heart muscle, so the minimum dose, and then conversely in the haemophilia studies using the same type of virus they did find some toxicity at a very high dose. So we stepped down from that the highest level to try and find what we felt was a safe range. And in that study, it was a small number of people, but they show that even in this, it was 9 people receiving the highest dose, 14 people received the dummy dummy drug of medicine, and actually, at 1 year, there was a very big difference between the two groups. That's to say, the people who received the highest dose had less emergencies into hospital, less breathing trouble, they could walk farther, and one of the sad things about heart failure is it is a malignant disease and it can cause people to die. And in the high-dose treated arm, there was nobody died, whereas in the placebo-treated arm, a group of people, as per their natural history of their disease, unfortunately passed away. So there were some signals, albeit in a small number of people, that this could have benefit. The other critical thing, and I think Richard alluded to this slightly, is it was safe. So we look at a number of different parameters to determine whether there's toxicity to the immune system, if there are any new cancers triggered, and on all the screening there was no evidence of this, at least in the window of the study. Of course, that was 1 year that was published. In fact, I had a meeting yesterday where we discussed the 3-year data, and the results are still showing the same evidence of benefit and safety out at 3 years. But it's only 3 years. It's still a relatively short period of time. So on the background of that, what has now been planned is a much larger trial where we're going to study 200 people who've got what we call advanced heart failure. They're on the best current medicines, but they're still very breathless, still having emergency admissions with heart failure into their local hospitals. And of these 200 people, 100 will receive a dummy drug and 100 people will receive the gene therapy. And in the UK, the trial is going to occur in a number of countries across the world, North America, the UK and a number of other European countries. The drug has been assessed by the regulatory authority for the quality in which it's made. That's an agency called the MHRA, and it's received its MHRA license. We actually presented to GTAC, the Gene Therapy Ethics Committee, in September, and they have overall been very happy with the structure of the trial and the ethical issues. We have to make some minor changes to various parts of the literature, but essentially looks as though we've got a green light to progress in the UK with this trial. So our hope is that either in December or possibly January of next year we'll launch the trial at the Brompton to start seeing whether this treatment really works. And what I thought I'd do is I'd finish with a video which is a cartoon of how it's delivered, which might give you a flavour. This is obviously a cartoon rather than a real human. So let's see if this runs. Okay, so we have a heart here that's beating away. It's meant to be a large, maybe slightly weaker heart, the fatiguing heart, and then there's a procedure called a coronary angiogram that goes through the artery in the groin. Many people who've got heart problems may have had a coronary angiogram. And then this gene therapy, here depicted in green, is injected slowly in a single infusion down the coronary arteries. And you can see the little green particles. It comes out of the bloodstream and into these units of the heart muscle, which are single cells. A virus goes in and it delivers in blue the DNA of the gene that we wish to deliver to the cell, and then the DNA makes a special coding message in red which makes the new protein. This protein builds up a reservoir of calcium in the cell, and it makes the heart beat stronger and harder, and that's what happens in the cartoon, of course. So with that, I think I'm going to pass over to Sian for part 2, which is about stem cells, and then I'll be happy to take any questions.
Well, hello, thank you. Thank you, Alex. I'm Sian Harding. I'm a scientist, an academic scientist, and I've been working on heart failure for most of my career. And I'm going to talk a little bit about cell therapy, which is probably about 10 years further back even than gene therapy in terms of it coming online, and a lot of it's still science fiction. And so just wanting to make the point that whereas Alex was talking about the gene therapy in terms of bringing the heart back into that sort of first phase after some injury, where actually it's doing quite well. Actually, it's compensating well, and it's able to support everything you need to do. And so what we're trying to do is bring back the heart into that. Where what cell therapy is trying to do is give you more heart muscle. And that's because unless you get back some of the damaged muscle, then your heart is never going to go back to its normal, healthy state. And the heart itself, and this is a bit of a bad design, I think, for whoever, doesn't repair itself very well. Unlike the liver, which does repair, or your skin, which, once you cut it, will repair itself, the heart has very little self-repair. Actually, we thought for a long time it didn't have any self-repair at all, and it's only much more recently that it's been found that there is a very small amount of repair. One of the things, of course, people are trying to do is to stimulate that repair. What they've also been trying to do is to put back cells in order to produce that repair. And what we're trying to put in is stem cells. And stem cells are cells that will first replicate. They don't have any sort of bias of their own. They're just undifferentiated kind of cells. They can replicate very well, and then they can differentiate. They can turn into all sorts of different things. That's why they're called stem cells. They're the stem of all the different tissues. And so people have been trying to find ways of stimulating or putting in stem cells into the heart. And there are various kinds of cells. There are cells that are stem cells in your body. As I said, there are points of repair. And one of the places that you have stem cells is in the bone marrow. And one of the first experiments that's been done, and the first clinical trials that have been done, so we have some clinical trials, we have some data to go on, is that the people have had bone marrow extracted and injected into their heart, either directly into the heart muscle, or just infused very close to the heart down the coronary vessels. And about 1,000 people have been treated in a proper, controlled clinical trial. Probably quite a few more have been treated in clinics where they can just be taken and pay for this, but not so much is known about this. The results, I mean, one of the interesting points in terms of the ethics is this placebo. And as Alex has quite rightly pointed out, you have to have a way of knowing who's been treated and who hasn't. So you have to have the patient not knowing this. You have to have the doctor not knowing this, so you can have a fair trial. However, if you're treating somebody with their own bone marrow, they pretty much notice if they've had some bone marrow extracted from their hip or not. So it's very difficult to fool people that they're having the placebo treatment. And there was a lot of arguments, ethically speaking, about whether it was ethical to take bone marrow from somebody's hip to make them think they've been treated, but not injected into their heart. And it was a long time before it was felt that that could be a proper placebo-controlled thing. Anyway, the bottom line is we do know quite a lot about this now. And actually, the bone marrow injection back into the heart does improve the heart very slightly, perhaps by about 3 or 4% in terms of the amount of blood it can put out. But what it doesn't seem to do is to produce any more muscle. What it seems to do is to be a bit like a coronary bypass graft and give you a bit more blood vessels into your heart. So the holy grail of getting more muscle is still not there. And this is what led people to be very interested in the human embryonic stem cells. Now, these were discovered in 1998, and they are usually obtained from embryos that were produced for in vitro fertilization. Then when a couple has these embryos, they generally store some frozen until their family is complete. When their family is complete, they're asked if they want to continue storing them, or at some point they have to destroy them because of space requirements. And at that point, they're asked if it's possible to do some experimentation with them. Now, these are very early on. They're probably 4 to 6 days, perhaps up to 10 days after fertilization. So they're not embryos in the sense of having arms or legs or any kinds of consciousness. They're really a small ball of cells. And some couples, particularly people who've been having in vitro fertilization, to choose embryos that have not got a genetic disease, like Huntington's disease. You can screen the embryos and only implant the ones that don't have the disease, so you have the diseased ones left. Particularly people like that have been happy to give the embryos for research. And it's been found that in these embryos there's a small ball of cells that which are stem cells, and which will replicate and come out and expand and expand and expand, and then they will produce this beating cardiac muscle, which has just stopped beating. I'll just get it beating again. It will produce every kind of cell in the body. It will produce every kind of cell in the body, in fact, but we used to use particular ways to get it into cardiac muscle. So it will produce this cardiac muscle. And you can see that this is genuine beating cardiac muscle by all the criteria that we have, and I'm very used to looking at the cardiac muscle. I don't actually do anything with embryos. I have to, I get them from the stem cell bank, because these are all lodged in the UK stem cell bank, and then researchers just ask for them and we're given a vial of cells. We don't do anything with the embryos themselves. But anyway, you can see very clearly that there was an ethical problem with those. Many people had a lot of problems with the idea of destroying an embryo in order to produce these cells. And so it's been very interesting that, and you might have been looking at the Nobel Prize ceremonies recently. In the last week, somebody was awarded the Nobel Prize, this Professor Yamanaka, for producing a method for getting something very like an embryonic stem cell, but from skin cells. And so now I could go to any one of you. I could take some skin cells or some hair follicle cells or some blood cells. We treat them with the factors. They've got scientific names out there, OCT4, SOX, etc., which were found by these people to produce reprogramming of cells. Could treat your cells with that. They would become something like embryonic stem cells. I could then turn them into cardiac myocytes, beating cardiac muscle, and I could either, in theory, this is in theory still, transplant them back into you, and because they came from you, they should be immune matched to you, and so the hope is that they wouldn't be rejected in the same way. The other thing, because I'm a scientist and I like doing these things, the other thing we can do is study these cells in a dish. So if you had, for example, a mutation, a particular mutation, you can take the cells, make cardiac muscle, then put them in a dish, and they will produce the same kind of problems in terms of arrhythmias or poor contraction or something that you would see in the patient. And you can try out drugs on the cells before you can try them on the patient. And that's been done. There's been a number of successes in that area, and the pharmaceutical companies are very interested in having patients' stem cells and the myocytes from them to test their agents on before they go back into the patient themselves. So getting more and more and more science fiction now. And I'm going to stop there, and then we can start our main discussion. Okay?
Good. Well, I found that fascinating. I'm sure you did too. And I have the exciting task of moderating your discussion. I'm sure there are lots of questions people would like to ask of me and Sian and Alex. So who'd like to start? In the front here.
Which of the chromosomes are the active genes on that stimulate muscular activity? Is it sex-linked or not?
It's not sex. It's not on the X chromosome. No.
No.
I couldn't, to be honest, tell you offhand which chromosomes those genes. I'm terribly sorry.
Right.
That's too scientific a question for me.
I was just interested in the question of X chromosome inactivation, because you were picking out something. Had they been on the sex-linked chromosome, that might have interfered with the question of picking out and using the cells from these embryos.
Maybe also just as a general piece of knowledge, which is that each of our cells has all the genes within it, but then the cell will turn on and off the genes that are important to turn it into its particular type. So a brain cell will turn on the brain cell genes, but turn off the liver, skin, heart, and so forth. And so thus, when we're thinking about heart problems, we're focusing on heart genes rather than liver and other tissues. But every cell actually has the full instruction kit. It's just selected which parts of the instructions it's going to use for that cell.
Yes, here we go. Kicking off.
My question is, what actually makes the genes switch off? Is it the environment that the heart finds itself in because of the damage that then the gene switches off and therefore the level of protein falls? I'm just intrigued why it switches off.
So I think as an analogy, that's exactly correct, because one thing that's become apparent from all our research in patients is it doesn't matter the cause of the heart injury. This fatiguing process seems to be a common factor, and therefore whatever is putting the stress and strain on the individual cells and the molecules within the cells ends up with this special gene being switched off. Then the question is actually what is the molecular process that switches it off, because if we can work that out, maybe we can switch it back on rather than having to replace it. And Sian and I are both looking into this because we think that that could be a future strategy worth pursuing. But currently it's not known at the very specific molecular level exactly what turns off this. There are some features that in some ways allude to what you said, which is lots of stresses and toxic strains that occur at molecular level that may contribute, but the actual way is still an unknown.
And the reason why the heart should suddenly shut itself down and work less well is interesting. It's probably because the stress is something like adrenaline. It's only expecting this for a short time. And so actually to have the stimulus for a very long time gives you something abnormal. But what it seems to be doing is to shutting the heart down into almost a bit like a younger form, a fetal form, which it needs less oxygen, it doesn't contract quite as well, but it's a bit safer. And so it's reacting by trying to keep the heart a bit safe, but not being quite so active. But it doesn't expect to have to do this for a very long time.
And I may say as well, and Sian will smile when I say this, but actually one of Sian's early bosses was a professor of cardiology, Peter Harris, and then subsequently my previous boss was Professor Paul Wilson. And both of them developed the concept that actually in evolutionary terms, if you have a low blood pressure, it's because you're bleeding. It's because the saber-toothed tiger has just attacked you and you're bleeding, and therefore the body turns on lots of systems to retain water, to retain salt, to push up your blood pressure. Now that we're living to older ages and people are developing low blood pressures because of a weaker heart, the system has got it wrong, because it's actually putting more strain on the heart by thinking there's less blood around and trying to hold on to more water and salt. So that's one of the problems, is this then presses the accelerator of the weakening and fatiguing of the muscle, which is why current treatments are very good at trying to block those accelerators. And they've been very effective. So there has been a lot of success in the last 2 decades on medical treatments to stabilise or slow the fatigue. In some people, it can reverse it, but in the majority of people, it's slowing the fatigue, the current treatment, whereas these new paradigms are trying to really reverse it and recover the heart back to either a normal state or a near normal state.
Yes, I understand that. But if you're then putting in the gene therapy, aren't you almost giving a positive feedback to the system? That you would, because the heart muscle has been damaged and remains damaged, the genes that are going into the heart muscle which isn't damaged, therefore they're doing more work, and aren't there more stress factors?
What a good question.
That's a very good question, which is the sort of question that gets fired at all of these new treatments. And maybe as a bit of background which would be helpful is current medicines which make the heart pump stronger and harder, and can effectively make it pump stronger and harder, accelerate the deterioration. The concept being that if you've got the fatiguing muscle and you keep beating it, it just fatigues faster and faster. You're never giving it a rest. At a molecular level, for a number of reasons, this particular protein, which is why I think of it as a sort of key conductor, is able to develop a more efficient pumping strength in a very efficient way in terms of the heart's energy. And it actually can initiate a recovery process rather than driving a worsening fatigue, at least from what we know so far. And there have been a few examples in people who've had various treatments for other reasons in heart failure, such as mechanical pumps, which suddenly take the stress off the heart, where we see the activation of this gene as part of the recovery. So there are a number of signals that this might be a good route to pursue, albeit that we don't know the answer, which is why we have to do the research trial.
Can gene therapy be used for veins which have replaced blocked arteries, for example, in coronary bypasses?
So the short answer is, in theory, yes. And I'm aware that there are some research trials that are being performed.
Yes.
Sorry, but can't.
Sorry, thank you.
Maybe I'll stand up and then I can see you. So there are some research trials that have the sort of context that when the surgeon during an operation, so you're asleep having your bypass operation, the surgeon actually takes the vein from the leg and uses it to sew it onto the heart to bypass the blockage. But there's a time gap between when he or she has cut it out of the leg and when it's sitting on the blankets on the trolley ready to be sewn into the heart. And that time window could allow us to treat the vein with something that we might think makes it better, be it a molecule approach, a drug, or a gene therapy approach. And so there are some studies where, for want of a better word, these veins are being marinated in a viral solution for half an hour to an hour to hopefully get the virus to deliver the gene into the vein to make the vein a more efficient bypass. So again, so that is happening in research trials, but will it work? Does it work? I don't know.
Yes, thank you.
It seems that in the United States there are some companies which are working on the idea that there are dormant stem cells in damaged heart muscle, and that if you can bring the appropriate growth factors into contact with those dormant stem cells, you can activate them and reinforce the damaged muscle, which in fact is very much on the road to regeneration of the damaged organ. Would you like to comment on that? Yes,
and that's an interesting point, and it would certainly be much easier to do that than to implant these cells. And as I say, the amount of regeneration in the heart is small, and whether that will ever replace the something like 2 billion cells that die in a heart attack is the big question, whether we can ever bring those two sides together. People have also tried to biopsy the heart and grow out that very small population of cells and reimplant those in the same kind of way. But certainly a small molecule approach would be good. One thing we do have to bear in mind, though, is that when so the heart is an organ with very little regenerative capacity. We have to bear in mind the idea that if we try to stimulate those, we have to think about the other body systems where you've got quite high regeneration, and actually to tip that even higher might tip it into a cancer. So we have these problems, and we have to have quite a delicate balance, because many of the things we think would be good to do with the heart, grow new blood vessels, might actually stimulate some cancer growth, and we have to be extremely wary about that.
I may also make a comment, and I should preface it by saying I'm an agnostic when it comes to gene therapy and stem cell therapy. I think there's a place in the future for both. So just because I've spoken about gene therapy doesn't mean I don't believe there are going to be some opportunities in the stem cell therapy. But one of the lessons that has been learnt from the bone marrow stem cell studies to date, and may translate to stimulating the heart's own resident stem cells, is the fact that when the experiments have been done in the laboratory, they've been done on very young, healthy animals, where the quality of the bone marrow or the quality of the heart's own stem cell is great. It's a lovely product, if you wish to use it and think of it as a treatment. Now we have an issue of a fatiguing, diseased heart. And the stem cells in the heart are probably under the same stresses and fatigue and toxic changes that are occurring in the muscle. So you're stimulating a potentially inferior quality product compared to the preclinical studies. And the analogy is in the bone marrow trials, taking bone marrow from often people in their 50s, 60s, 70s. They may have chronic other diseases such as diabetes, hypertension. They've shown that the bone marrow actually is quite inferior in its ability to be a stem cell compared to the teenagers that's often being taken out for things like leukemias and lymphomas and bone marrow transplants. So there's also an issue of what stem cell do you want, and the quality of, if you think of the advert, does it do what it says on the tin? And you want a cell that is going to repair the heart and make muscle, and actually maybe there are problems, and if we can rejuvenate somebody's own stem cells, that may be another good opportunity to explore.
Is there a time limit from the initial injury to the time the therapy begins, either gene therapy or stem cell therapy, when it's likely to be successful? Is it better at the beginning of the injury or the end, or is there a grading between the two? What is the situation?
So I'm going to approach that in two ways. So one of the critical things is how big is the injury. So if you have a very big heart attack, you may develop heart failure in the days or weeks after the very big heart attack. If you have a little heart attack, it may be 10 years. So there's the dose of the injury that determines how rapidly the heart fatigues after it. And some of the injuries are insidious, like having been born with a mutation of a heart muscle gene, having high blood pressure uncontrolled for 20, 30 years. So these things can creep up, or that can be a sudden injury like the heart attack, some modern chemotherapy drugs which are very good against cancer but actually are toxic to the heart. So I think there are a number of permutations or variables as to how rapidly it can occur. The next question is very sort of key and intuitive, which is, isn't it much better to prevent this rather than wait for it all to develop and then try and rescue the situation back? And if we take examples in our current treatments, ACE inhibitors and beta blockers, that data is now available. But as Richard alluded to, what happens is, to begin with, trials are normally performed on the sickest people with the weakest hearts, and there are a number of reasons for that, which maybe we can discuss. And once you've shown benefit in the very sickest population, the sort of people who may be needing a heart transplant, very weak hearts, then you can start to work backwards into the less sick, maybe less sick patients with still very weak hearts, and then you go back until you get to, actually, shall we start doing this at the beginning and seeing if we can prevent the development? But that's the natural evolution of how these trials work, and there may be ethical reasons for that, but there are lots of practical and not least financial reasons why it happens that way.
Can I just ask a supplementary question? Is it the same basis of the viral gene therapy that they're using for cancer treatment, or researching for cancer treatment?
So at one level the principles are the same, which is we're using a virus to deliver the gene which is the therapy, the therapeutic unit. But in the cancer world, it'll be to stop cells dividing in that cancer, and sometimes to trigger them to die themselves, to try and eradicate the cancer. Whereas we're trying to take the fatigued, weak muscle and improve it in an effective way, rather than keeping on flogging the weak muscle. So although it looks as though it's pumping harder, actually it's deteriorating faster.
Okay.
Does that make sense?
Yes, thank you.
Thank you very much for useful information. You say we use natural viruses now rather than ones that are pathogenic. Where do we get them from? And how do we get them to take on board genes and also deliver the genes? How's it all done? You know, it
Very
sounds
good
like
question.
magic.
So the honest truth in terms of how they were found is that they were just discovered by chance. And in fact, they were initially thought of the viruses we use are actually, all viruses are obviously microscopic, but if you take the virus fat world, these are the really tiny ones. So initially, when people were growing up other types of viruses in the Petri dish or in the test tube, this was seen as sort of contaminating dust, until people and the technologies advanced to a point where they could say, actually, this isn't just dust, it's a little baby virus, as it were. So then they were found in a number of sources, and one of the sources was the heart, which is then, in this group and family of viruses, how it became the first signs that maybe these have a predilection for homing to the heart rather than the tissues in the nose that give you a cold, or the ones down in your tummy and your intestines that give you diarrhea when you have a viral tummy upset. So I think that's how they were found. Why do they go to the heart? Well, it's about the way the virus is made, and on the surface of the virus there are lots of special viral proteins, and those proteins, and it's like a signature, like a fingerprint. The viruses, a family of viruses, will have the same fingerprint, and that fingerprint will tend to say that virus will go to a liver, go to the heart, go to the brain, and so forth. What's now evident is these viruses haven't just arrived and suddenly materialized. They've been there for centuries, thousands of years. But what is clear is that they don't cause any known disease. So how you then describe them or the terminology to use, and it will be very interesting to discuss. If I'm now speaking to a patient who may be potentially eligible for the study, what's the correct terminology for what is a virus but doesn't cause a disease? And how that should be portrayed when we're inviting people to participate but not pressurizing people to participate.
one way to think about it is to think about the way in which we live in an environment where we're all exposed to viruses and bacteria all the time, but some of those viruses cause illnesses in animals, but not in us. They're harmless to us, but they might give your dog canine distemper or something like that. It's a good thing we don't have it, because we were going around with these cones around our necks. And so some of the viruses that are used are viruses that do, in fact, cause disease in animals, but are harmless to us, even though they do some work at the level of the cells. The other thing is that just think how popular it is for people buying those little drinks in the supermarkets even, where they're ingesting large quantities of bacteria, and they've convinced themselves this is good for them. Maybe it is, but people can take on these sorts of microorganisms, if you like, and be completely happy about it. It's all a question of how you think about what we're doing.
When you're delivering the gene therapy, how can you confirm that the cells will actually take up the DNA? How do you know whether this cell has actually taken up the DNA?
So that's a great question. The answer in the current trials is we don't know, except that we can measure the heart function, do heart scans, look at how the contraction and relaxation of the heart is before the treatment is received and afterwards, how various levels of markers in the blood that reflect strain on the heart, they tend to go up if the heart's getting fatigued, and in the placebo arm, the people receiving the dummy drug, they continue to rise over time, whereas in the patients who received the active treatment, they either stabilized or actually improved. And then there are a number of, and then how does the person feel? What's their symptoms? Have they been into hospitals? So there's the sort of cardiology type ways of assessing whether it looks as though it's worked. In terms of has the gene got into the muscle and made the new protein, the only way to do that is to actually have samples of heart tissue. Now, at one level, we could introduce that into this study and say, can we take a biopsy of your heart at the beginning, before you've received anything, and then you'd need to come back again at some point and have another angiogram and another biopsy. And that introduces interest and benefits for the scientific community, but of course it also introduces risks. One way round that, and the way that we have decided to progress, is with Sian, we have liaised with the heart transplant centres, that's Harefield Hospital and Papworth Hospital. And in those hospitals, they have some people who, rather than having a heart transplant, have these mechanical hearts I mentioned earlier. They're called ventricular assist devices, which are inserted to try and take the strain off the heart and keep someone alive, either to get them home, and in America you're allowed to go home with an assist device and live with the device. In the UK, and this is a political and economic issue, you're only allowed to receive one of these devices if you've been accepted for a heart transplant, with the vision being that then this device keeps you alive until you have the transplant. Reality now, as time goes on, is we've realised more people can live with them, at least for a short phase of maybe 3 to 4 to 5 years, possibly longer, but that sort of level. But they're very expensive, and if we start saying everyone can have them, we could bankrupt the NHS quite happily, very quickly. So to get round that, from Whitehall, it has been decreed that you're only allowed to be accepted for an LVAD if you've been accepted to go on a transplant waiting list. And because that's so restrictive, it's a rather clever way of restricting the availability. Now, when the pump is put in, the surgeon takes a little bit of the heart muscle out to put the pump in. So that little piece of muscle we can then store and do some research on, and then what our plans are is to have a trial which will start next year at Harefield and Papworth, where people who've got these pumps inside will then be offered the gene therapy or a dummy, and then they will have one follow-up biopsy that can be done through the keyhole approach to measure whether the heart enzyme, the genes and the protein have got into the heart muscle. And because they've got the backup of having the pump there, the risks of the biopsy are less than if you didn't have the pump there. So that way, we hope to be able to say, yes, if you receive the gene therapy, it does do what it says on the tin. It does deliver the gene into the patient's heart muscle and produce the protein. And because there's the dummy arm, and we won't know who's got what, received which, when we're analysing the heart muscle tissue, we'll work out whether it's there or not. What would be thought-provoking is if we can't find it, but the hearts get better.
Well, that's the other sort of question. When the gene switches off, is there ever a chance that it can revert back to being turned on?
So there's a very small minority of people with very sick, weak hearts who then, when they had these ventricular devices, assist devices, this mechanical heart pump, the heart actually got better. And it got so much better that rather than needing the transplant, the surgeons were even able to take the pump out. And when they took the pump out, they had to take a little bit of heart muscle with the pump, so you can measure it. And interestingly, the gene that we're using as a treatment, it's called SERCA, spelt with an S, but it's SERCA, that goes down in the fatiguing heart, and it was down in the core of the tissue at the time the pump was put in, but in the group of people who did much better, the SERCA levels and what happens to the heart because it's got its SERCA back was all showing that signature in the muscle, whereas the individuals where they didn't recover the heart, it stays low. So that's the sort of nearest we've got to a signal of another way of boosting this function of this protein.
So potentially we could target a way to revert, to switch on the gene again.
Well, I think that sort of leads back to what we were saying earlier. I think that would be a very interesting way to do it, but we don't have the tools to do that yet. So maybe in 10 years' time at the Café Scientifique we can talk about that one.
How about someone with a congenital heart problem, like the Eisenmenger syndrome, for example? My daughter had that. Is there any research, stem cell or gene therapy, that has done anything, or is there any hope or whatever? Has there been any research in that area when it comes to that disease?
Okay, so just maybe if I can just summarise what Eisenmenger syndrome is for the audience and people who may not know. So you may be familiar that a number of children and babies are born with holes in the heart, and if you have a hole in the heart that's left unclosed, it causes a short circuit of blood between the left-hand side of the heart and the right-hand side of the heart. And over many years, it depends how big the hole is, but over many years, this causes increasing strain to the lungs and then backwards from the lungs onto the right-hand side of the heart. If it's identified in time, it can be closed, and then at least you've removed the original problem. But once the horse has bolted, so to speak, and the damage to the lungs has got so severe, actually closing it at that stage becomes dangerous. And unfortunately, initially that was the treatment until the surgeons who were closing the hole realised that that group of people didn't survive the operation and get home. So then we were left with, well, what happens and how do we treat those people? And I think the experts and specialists in the field have developed advances in the last 5 to 10 years of medicines, drugs that can help support. They're not curing the problem, but they're helping people with the Eisenmenger syndrome to live longer and feel better for a longer period of time. But it's not a cure. Then the question comes, could we have a gene therapy? In theory, that even the gene therapy we're using to repair predominantly the left pumping chamber could equally be used to treat the right pumping chamber in people who have a weak pumping chamber on the right side of the heart. Once we talk about the specifics of Eisenmenger's, it gets a little bit more complicated, but the perception is there. And finally, a little bit more, although not the whole story, is known about what genes may cause the holes in the heart in the first place. So if you can understand and see, let's say in a baby, in a mummy's tummy that has got the hole in the heart on the ultrasound scan, currently that child, when it's born, at some point in its life will probably get the hole closed, so it never develops this irreversible problem, because now prenatal screening is so good. But one could conceive of another option to the surgery, which is to have the gene delivered into the baby in the womb to reverse the cause of the hole being left open and allow it to close naturally. But that's science fiction.
There is a group actually at UCL who are working on prenatal gene therapy.
In utero gene therapy for very severe brain diseases and things has been explored. So the principle of delivering a gene therapy to the baby, the fetus in the mummy's tummy, once you've got a diagnosis that you think needs to be dealt with, is real. Doing it for holes in the heart, still a long way to go.
If I can just add that I have actually studied some cells from the Eisenmenger patient when they had a heart transplant, and I was able then to look at the cells from the tissue. And actually, as Alex was saying, whatever you start with, whatever kind of injury, that change in the cell is very similar, and I found that to be the same. So it's potentially this gene therapy could do something for that.
Can I ask a question about post-surgery? This is to do with congenital conditions in particular, where the heart's been operated on and there's legacy issues with scarring afterwards, which cause arrhythmias, sometimes sudden cardiac death type arrhythmias and that sort of thing. Is there any of these kind of therapies being developed or looked at to kind of repair the damage done to the conducting parts of the heart, you know, where obviously the heart goes out of rhythm?
So I think the way I may answer your question is to slightly divide it into two parts. The first part is what you mentioned about the risks of the electrics being disrupted, resulting in a cardiac arrest. And that can occur for a number of reasons. Partly the fatiguing heart, if the muscle is got that fatiguing signature that we call heart failure. And one of the interesting paradigms or differences is those medicines that flog the heart, make it pump stronger and harder, but actually accelerate the decline, they really stir up the electrics and cause cardiac arrest more frequently. Circa gene therapy that we have studied, at least in our studies in the laboratory, and there's been no suggestions of increased risk in the small numbers of people studied to date, but in the laboratory it's reduced the arrhythmia risk, it's stabilized the electrical disturbances. So in a way you start to get a win-win, because it's making the heart pump with more efficiency. So it pumps stronger, it relaxes more efficiently, which is important, particularly when you're walking along an upper hill and exercising. But it does it in a way which is also stabilizing the electrical activity of the heart. So maybe the risks of sudden death from a cardiac arrest are reduced. And in fact, that's a particular research trial that we would like to do at the Brompton. And we've put in one application and it came back for funding, this is. So we're about to plan to put it back in again, because we think particularly for people who have defibrillators that are going off, there could be a value for trying to help them by calming the electrics. The second part of your question was about the natural conduction system, and in some people, particularly if they've had operations, or potentially people who've been born with changes in the conduction system, which is like the natural electrical wires of the heart, so the signals can't get from the top to the bottom. And the modern therapy for that is a pacemaker. So a pacemaker is a box which has lots of electronic programming, a battery, and then there are some wires and leads that go down into the heart. But it is a piece of artificial material going into a body, and therefore it causes problems and the battery eventually wears out. So there is a whole field of stem cell research to try and develop biological pacemakers from stem cells to regenerate the natural conduction pathways in the heart. And in the animal studies, they've been encouraging results. But to my knowledge, there's no planned clinical trial of this yet. I think it still has to be really optimized, the best way to repair the electrical conduction wires of the heart. But it's work in progress.
Looking into the future, when these therapies hopefully become standard part of treatment, will it be a one-shot thing like a bypass, or do you think there'll be a course of treatments, or will it be permanent like sort of ramipril and beta blockers? And the other question is, you mentioned 10 years. I mean, this is probably a silly question, but if the trials go as well as you might be hoping, when do you think these therapies will start to creep into sort of general treatment?
Okay, so the first question, which is a very important one, is how many treatments do you need? Now, there is data from 2 sources which may suggest you only ever need 1 treatment. The 2 sources, first of all, in the animal studies, when they were first developing the gene therapy for haemophilia, haemophilia is a disease where you're missing one of the clotting factors in the blood. And they were able to put the human clotting factor gene into a virus, and it was one of these viruses, the family that we're using, and they injected it into the muscle of an ape as part of some primate research studies. I'm not going to go into the ethics of primate research studies. We don't do them, but that's what was done. And when they did this single injection, they then could measure in the blood this human clotting factor, because it was different from the primate's own ape clotting factor. 9 years later, it's still being produced after a single injection into a healthy animal, and that's where the caveat is. In the haemophilia studies in patients, and obviously it's when did they start determines how long we know, now out to 4 or 5 years after a single injection, the clotting factor is still being made. So the principle that these viruses can deliver a gene therapy in a single dose with a long-lasting effect is very plausible. The question is, what happens in that fatiguing heart? And if I had to extrapolate from experiences with other treatments, there will be some people who their hearts recover back to normal and stay normal, and they'll only ever need the one. There'll be some people who it recovers back to a sensible level, which is fine for life, and they never need anything. It doesn't go back to normal, but at least it's stable. And I suspect there'll be another group of people where initially it'll improve, and then over time the fatigue will creep back. What do we do then? Because an issue we haven't discussed yet is the fact that, like any viruses, if we have infections, you develop an antibody to them. And once you've received the treatment, you develop the antibody to the virus, and that blocks you having another dose, because the antibody in a way sweeps away anything you infuse in, and it doesn't work. So before we get too despondent, we don't know even if this works, but should that process fall through, then the virologists are already busy saying, well, actually, the antibodies are binding to this part of the fingerprint on the surface of the virus. So why don't we, since we're making these viruses in the laboratory, just engineer out that bit that blinds, that key to the lock, so that actually now you can have a virus that the immune system can't see, it doesn't have antibodies to, and then you've got round the issue of antibodies. That may take a lot of time, because that requires then lots of toxicology to show that the bioengineered virus is safe, but that's the most logical scientific way. How could we do it in the next 5 years or 10 years if we don't have that data? Well, a lot of patients with immune diseases driven by antibodies go and have their blood sieved, for want of a better word, by a machine that actually scoops up all the antibodies out of their blood. So you could conceive of a patient or somebody who's had a benefit, they've done well, but 5 years later now they're back and breathless, their ankles are puffy again, and they need another dose of the gene therapy, and you sieve their blood for the hour before you then deliver it so that there are no antibodies around whilst the virus is delivering the treatment. So I think that's a sort of low-hanging fruit approach, but actually scientifically the engineering is the wiser way to go.
And if you want the answer to the same question for the cell therapy, well, you don't have such immune problems there because either it's your own cells and you're matched, so that's okay, or you're not matched and then you have to be immunosuppressed like you do for an organ transplant. It's one or the other. We have a lot of problems keeping the cells there. That has been one of the biggest problems in that they can be there for a while, but within days or weeks they tend to be cleared. And that is in animal models we're talking about now. And so under fairly ideal conditions. And so it's keeping the cells there that's a problem. So it is possible that it might have to be repeated administration, but we just don't know yet.
Just to use my privilege a little, one of the things that people may have heard of is the banking of umbilical cord blood for stem, as a source of stem cells that are going to be well matched to you. Is this going to be useful for your purposes or not?
Well, they've got quite an interesting sort of phenotype in the sense that not only would they be matched to the baby from which they came, but there's a suggestion that they might actually even damp down immune responses. So, for example, to be put into non-matched people, or even to be put in with some other stem cells to damp down with the immune responses. So that's quite an interesting feature of those.
I've got a couple of questions that were completed on the form, so quite good to get some of those in before the end. There's one question from someone whose daughter, family cardiomyopathy is in the family, doesn't know whether the one-year-old daughter's inherited it yet, but wants to know, if so, when could stem cell therapy be available? And another question that might be related to this is about age limits for clinical trials. So I assume it's a question around carrying out research in children.
Okay. In terms of the cardiomyopathy question, so if the concern is that the baby may have the cardiomyopathy, I think if I was correct, the implication is that the cardiomyopathy is caused by a genetic defect. That's to say there's a change in one of the heart muscle genes which causes the heart to fatigue faster than it should otherwise. And that's what we call an inherited form of heart failure. Now, and in fact, the Brompton have set up a specialist service specifically for the inherited heart failure conditions. I think that currently they should be carefully monitored, and in the event that we think that fatigue is developing, the heart is starting to fatigue, that we would use current standard best medicines for fatiguing a heart, that's heart muscles. I think in the future, if the problem is a problem in the gene, the solution is a gene therapy to replace the diseased gene with a natural, healthy human gene. And there's already quite a lot of work exploring the ways that can be done to try and correct the genetic problem in the heart so that then it doesn't fatigue. But I suspect, like I alluded to, for heart failure caused by other conditions, you will probably start with children or adults who have the most severest form before working backwards to potentially teaching children in their childhood to prevent them developing it in their life. But again, in the sort of science fiction approach, that's where it will probably be in 20 years, 30 years' time, where you'll have a genetic screen. And genomics is getting frighteningly fast, and in fact, you may be aware now, for well under $1,000 you can go and get your whole genome assessed, whereas 10 years ago it would take $1 billion in a lab and 200 scientists to do it. So therefore you can get all these signatures of what may or may not be abnormal, and the problem is as it generates so much information, we're not quite sure yet in the medical community how to deal with it all. But if there's a very specific family that's inheriting a problem and it's very clear across the family, and the gene with the abnormality can be very precisely defined, and then a baby is born with that gene, it may be a safe and logical solution to try and treat the baby, or when it's a child, it depends what the disease is as to how severe it may manifest in childhood with a corrective gene therapy. So I think that's very plausible. The second question may be from someone who was at my Gene Therapy Advisory Committee board in September, because we were asked this ethical question at the other end of life. And maybe I'm extrapolating that, which is for our current trial, the age range for acceptance into the trial is 18 to 80. And the question was asked, why 80? That's ageist, isn't it? You know, what about the 81-year-old? So again, in theory, the treatment may very well be applicable to anyone independent of what their age is. At a practical level, when we're organising how to do a research trial, it's very inefficient and ineffective to have people who may have problems other than their heart in the trial, because then if they're having problems with other parts of their health, then that will influence whether they're in hospital, not whether the heart is better, and then you get a misinformation in terms of whether there's a benefit or not. And various studies looking at what the likelihood of getting these other problems, general health problems, show that once people reach their 80th year, on average, these go up very rapidly. So it becomes a very inefficient way of running a research trial to look at one condition, unless your condition is aging, to start to enrol people who are over the age of 80. So it's not to say that they won't potentially benefit in the future, but in order to have a sensible trial with a sensible number of people and not have what we call in statistical terms the noise of lots of events that are nothing to do with the heart influencing how people's health are in the trial, a line has to be drawn. And once you draw a line, you always joke, or not joke, but you always say, well, how is a 79-year-old different from an 81-year-old? And the answer is, of course, they're not. But you have to draw a line somewhere. Then the question is, where do you draw the lower line? And for 18 is obvious, because you need to have adults with consent. But maybe Richard can comment.
I mean, this is what I do, right? So one of the things, just developing Alex's point, there's no particularly good reason for an age cutoff. What you want are criteria for this experiment, because a clinical trial is an experiment, that will allow you to say that it was this treatment which had the effect we're measuring and not something else. And so with the older you get, the more likely to have more things wrong with you. And the more difficult it is to interpret the data, the more chance it is, for example, that if you're measuring deaths on study, that it might be caused by something else, and it's not caused by the heart failure, and it's not caused by your gene therapy, it's caused by something else. And so this is noisy. This is bad from a scientist's point of view, because they want clean data and easy comparisons and tidy statistics. But for the rest of us, well, I don't know how easy it is to infer from a nice, tidy study published in a leading journal to whether this is going to help me when I'm 85 and I've got congestive heart failure and I've got diabetes and I've got some cognitive problems as well, which is how I'm likely to be given my family history. And so this is one of the big problems in medical research, is how you move from good, well-conducted, well-designed clinical trials to real clinical life. That's one of the issues, isn't it? For the young age, treating children in trials is not, cutting to the chase, essentially more difficult than treating children out of trials. You make a decision in terms of what's in their best interests and what's in the interests of this child rather than anybody else. And one of the big problems in medicine is that we don't get enough trials in children. A lot of the time children are treated when things haven't been properly evaluated because they haven't been allowed to do the trial for one reason or another. And if you think that's odd, you'd be right, but then reflect a little. If you have a child who is seriously ill and you're told that there's a new treatment which might help your child, quite likely you're going to want it. And you're going to want it without having to go through the rigmarole of saying, well, you have a 50% chance of getting this and a 50% chance of getting something else which doesn't work. Parents find that difficult, and who can blame them? But that's the dilemma that they face.
I might explore that a bit more, because this is the whole issue of the placebo arm.
Well, or the standard.
Or the standard. But, of course, the other side of the coin is we don't know it's safe.
Absolutely right.
And so it's how it's presented.
Absolutely.
So the unknowns are the unknowns, as has been very famously quoted by many people. But so I think, you know, again, thinking as a parent and a child, you say, well, there's this new treatment that may work, but we also don't know if it's toxic. And it's the same for these things. What's the 10-year safety of the gene therapy or the stem cell therapy? We don't know, because the longest it's been in anybody is now 3 years. So I can tell you what the 3-year safety is, but not beyond that. And you can extrapolate that to lots of things. I mean, you could say, for example, I believe the oral contraceptive pill was really introduced in the 1970s. So now we have 40-year safety data, but we don't have any more than that. And so it's the same with all these types of treatments. As they arrive, you only have the safety data of what the first people were and are they still alive and what's happened to them. So I think there is always the risk side as well as the benefits, which is why you need the placebo arm to make sure that it's not risky as well as, and therefore it's safe as well as it's effective.
And if you're comparing with standard treatment, bear in mind that standard treatment itself has never been tested properly, usually. And the other poignant irony here is the only death, to my knowledge, worldwide on a gene therapy study was in a young adult, Jesse Gelsinger, of 18 years of age, who had an adverse reaction to the gene therapy. And the only reason he was on study was it was a treatment that would actually have been better delivered to 2- and 3-year-olds, but for regulatory reasons, they couldn't deliver it to 2- or 3-year-olds. They had to start with adults and work backwards.
I think we're now nearly 8 o'clock, so maybe we take just one or two.
I was just wondering if you had difficulty actually getting people to take part in trials, and also if the types of trials you're doing in terms of the numbers, how do you, compared to a normal clinical trial where you have much higher numbers, how does that work on your therapies where the numbers are much smaller?
So it's a very good question. So I always think that there are a number of massive hurdles to a successful trial in any field, not just cardiology. The first is funding. So for the BHF and the government, who I know are representatives in the audience, thank you for the funding, but preferably let's have some more of it. So first thing is funding, and otherwise it's commercial, and then as soon as you have a biotech industry or a pharmaceutical company, of course, then there are corporate agendas that have to be balanced against doing the trial or not doing it. So then once you've got the funding, and then you've gone through all these regulatory hurdles, which are appropriately stiff, so I'm glad they're there, but at the same time, trying to proceed through them is a challenge. Then recruitment is the next biggest barrier. So there's a general rule of thumb that if you have your list of what the eligibility criteria are for the study, and that's people have to have certain things, and also if they've got other things that you think should exclude them, there's that list. You need 10 people who are eligible for every one that actually you recruit for a number of reasons. So there's a big attrition in a general drug trial. Now, for gene therapy, it's a sort of double-edged sword at some levels, because on one hand I can see the real barriers are it's a virus, it's a gene, we don't have many years of outcome safety data, but then no one ever does when they start off with a new treatment. I've mentioned the antibody barrier? Well, actually, if you just measure the antibodies out in the healthy population, about 40 to 50% of people actually have the antibody already. So they're already ineligible for the trial. So I'm now thinking, right, that's 20 to 1, not for 20 people to be screened and eligible for every one person that we may enrol. The counter is, and I think Richard alluded to this, positively or negatively, the sicker you are, the more likely you are to want to do something. And I think because the type of people who we're starting for the trial is people either on a transplant waiting list, close to a transplant, needing to be on the waiting list. Many people, unfortunately, can't get on the waiting list for other reasons, not least age, going back to the ageism issue. Then this is a new opportunity. And if you're suffering, if you've been in hospital a lot, if you can't walk more than 10 or 15 metres before you start getting tired, and there's something new that might help, that's the incentive, I think, that may mean it's not 20 to 1. But again, this time next year, I'll be able to tell you whether it's been a breeze recruiting or actually it's been really challenging, because once people, once you say, well, 50% of the population aren't eligible because of the antibody, so now we're into the group who aren't. I will say, and as I said, we have a number of trials, so my approach to it in a practical way is if you're eligible for the gene therapy trial, but you'll have the antibody, so you can't then be in the gene therapy trial, we do have some other research trials that you may well be eligible for. So it's not just, right, that's nothing, that there are other opportunities, albeit that they are research as well. Oh, yes. Okay, I might let Richard answer that one. That sounds more ethics.
I'm Italian, so I'm loud. I don't need a...
Okay.
In an ideal future, would you comment on the worth of storing available pools? And are they, since I'm not a scientist, is it actually worth it in a case where you have an individual, maybe, anyone who has a serious congenital condition?
The storage is now becoming more routine, and you can actually there are banks like the Virgin Bank where some of them will go for research and some of it will be for treatment, and they will help you with the payment of the storage. The number of cells, the number of stem cells in cord blood is small, and so it's usual that they have to combine a number of donations in order to treat one child. But I think, on balance, it is reasonable to say that, yes, there are stem cells, there are useful stem cells in cord blood, and so it's a reasonable thing if it's not going to be a huge economic burden on you to store it, yes.
And as I said, is it of any use if as I said, because I'm not a scientist, if there is a serious congenital condition, does that affect also the cells in the umbilical cord?
I don't think we know.
I don't think we know unless it's very clearly a genetic condition. And then you're quite right to think that if the disease is a genetic disease and that gene is abnormal in the umbilical cells, that whatever stem cells you make from those umbilical cells still carry the abnormal gene. So you're putting a defective treatment back in, and I think that's a very logical argument. It's not proven. Then you could say, well, why don't we marry the gene therapy? And this is an approach that's being used in a way, what Sian alluded to with the Yamanaka approach of taking a skin biopsy and turning the skin cells into stem cells for that person. Well, what are they doing? They're giving gene therapy into the cells in the Petri dish. So it's a combined gene and stem cell therapy, and maybe for the umbilical cord that would be another sort of strategy. Correct the defective gene in the Petri dish so that you get good cells. It may be alternatively that science has got round this, because actually you can have a depot of best healthy young stem cells that are engineered so everybody's immune system can receive them, and you don't need to get your own ones back. You can just have these. I mean, to take it to an extreme, maybe we should all be getting Usain Bolt's stem cells, because surely they're the best. They'll be the fastest.
With Usain Bolt, we know the remedy. Apparently, it's lots of fried chicken. So we've run out of time, sadly. I had all sorts of questions about Lance Armstrong and gene doping and so on, but maybe we'll save those for another time. And I'd like to thank my colleagues very much for their extremely insightful presentations, and for you all for coming and participating in such an engaged way. Thank you.
Thank you.